Morning. It is a pleasure to join you with this video conference in the Thailand International Congress. I've been once in Thailand 8 years ago in Bangkok, and I hope I will be able to come back again once the COVID-19 pandemic will be under control. So today we are going to talk about vasopressor use for hypertension management during cesarean section under spinal anesthesia. Hypertension during elective cesarean section is very frequent, with an incidence up to 80% if not prevented when using single-shot spinal anesthesia. In addition, there can be other hemodynamic disturbances, such as alteration in maternal cardiac output or in uterine blood flow. There are many factors involved and combined to explain why this hypertension is so frequent during cesarean section. So caval compression by the gravid uterus, of course, but also the cesarean section surgery itself, which requires a very high upper sensory level. Spinal anesthesia also provides 3 times more hypertension than with epidural. However, it provides also a much better anesthesia, and this is the reason why it is used. And the elective setting of cesarean section versus cesarean section during labor also induces more hypertension and vasopressor requirements. What are the consequences of hypertension? For the mother, it is usually limited to nausea and vomiting, often accompanied by dyspnea that can precede, in fact, nausea and vomiting. But in more severe cases, it can be loss of consciousness, pulmonary aspiration, cardiovascular collapse, or even myocardial infarction that had been reported for the mother. For the fetus neonate, it is usually acidosis with low umbilical artery pH. But when hypertension is more severe or more prolonged, abnormal heart rate tracing can be seen, low ABGA scores, and even neonatal ICU admissions, cerebral palsy, and even death. Therefore, it is very important to correctly manage hypertension. And in this international consensus statement we released in 2018, we stated that the aim was to maintain systolic blood pressure above 90% of baseline until delivery of the neonate using a prophylactic intravenous vasopressor. And when systolic blood pressure falls below 80% of baseline, which defines hypertension, it should be treated immediately with a curative IV vasopressor bolus. You can see on this line and in these articles, in fact, that we deliver also a table with 90% and 80% thresholds of systolic blood pressure to help guiding the vasopressor management. And we advocated to check blood pressure every minute until delivery to guide the administration of phenylephrine. It is very important to understand correctly the mechanism of hypertension. In fact, contrarily to what was thought for many decades, there is no real decrease in preload, which means no decrease in venous return, at least initially, because the onset of venous vasodilation is quite slow after the intrathecal injection of the spinal anesthesia. But on the opposite, there is a very rapid and huge decrease in afterloads because there is a quick onset of arterial vasodilation after the intrathecal injection. Thus, cardiac output is maintained and even increased initially during onset of spinal anesthesia because of this arterial vasodilation. The decrease in blood pressure is in fact only due to the decrease in systemic vascular resistances, whereas in fact, the cardiac output initially increased and partially limits the decrease in blood pressure. You can see on this table the commonly used vasopressor, and namely ephedrine and phenylephrine. Ephedrine acts mainly as a beta agonist and has only a weak alpha agonist effect. It also acts indirectly via release of catecholamine, and it has a slow onset as a result. Phenylephrine acts exclusively on alpha agonist receptors. It acts directly and has a very quick onset of action. Ephedrine has been considered for many decades during the 20th century as the gold standard vasopressor in obstetrics. This is because of experimental studies that were performed on pregnant youths at this time. However, placentation in humans is very specific and completely different from this sheep model. In pregnant women, ephedrine crosses freely the placental barrier, as nicely shown in this study, looking at the umbilical vein to maternal artery ratio. And you can see that this ratio is 1.13, which means that there is 113% ephedrine on the fetal side when using ephedrine. Whereas with phenylephrine, there is only 70% that crosses the placenta. Thus, ephedrine increases fetal oxygen consumption by its beta agonist action, while hypotension at the same time decreases fetal oxygen supply. This is a kind of double punishment, and this explains why it is possible to see a very severe fetal acidosis when the dose used is too high of ephedrine, when it's above 30 milligrams, for example. Phenylephrine, on the other side, is now well established as the first-line vasopressor. As I said before, it has a low placental transfer in humans, 70% only. Also, it's a pure alpha agonist, which means a pure vasoconstrictor well adapted to antagonize the spinal-induced vasodilation. In addition, it provides no increase in fetal oxygen consumption because it has no beta agonist action. There is also no significant deleterious vasoconstriction on the utero-placental circulation in humans, contrarily to what was reported in the sheep experimental model. Therefore, usually there is no fetal acidosis with phenylephrine. What you can see that there was 20 trials put together, including over 1,000 patients, and that the true fetal acidosis was 5 times higher when using ephedrine instead of phenylephrine. In other words, phenylephrine provides much less risk of fetal acidosis than ephedrine. This is a nice study showing the different mechanism of action and mainly not only the mechanism of action, but mostly the effect of ephedrine and phenylephrine. As you can see on the right part of the slide, phenylephrine increases very quickly blood pressure. This is a dotted line, but this results in a decrease in maternal cardiac output, the gray line, and it parallels with a decrease in maternal heart rate. On the other hand, ephedrine increases both blood pressure, heart rate, and maternal cardiac output, but it does this more slowly. Of note, ephedrine total dose should never be above 15 milligrams to avoid fetal acidosis, but ephedrine can be used after first use of phenylephrine to counteract this decrease in maternal cardiac output and decrease of maternal heart rate. Another important question is when to use phenylephrine. Phenylephrine should be used prophylactically, not only reactively. Why? Because using phenylephrine prophylactically results in much less hypotension than when using phenylephrine reactively. And this has the consequences of also decreasing very effectively the incidence of nausea and vomiting. Another question is how to use phenylephrine. First answer is to use it in a way that maintains blood pressure between 90 to 100% of baseline. Most experts advocate the use of phenylephrine prophylactic infusion and using a low rate that is in between 25 to 50 micrograms per minute, then adapted to blood pressure. This is based on many studies, and particularly this one that shows, as you can see in the middle column, that the concentration, in fact, the dose rate of phenylephrine, 25 or 50 micrograms per minute, is the best compromise to have a low incidence of hypotension, but also a low incidence in reactive hypertension and a low incidence of maternal bradycardia. Whereas on the left column, where there is no phenylephrine infusion used, there is a high incidence of hypertension. And in the two rightmost column here with a high dose rate of phenylephrine, you can see that there is, of course, a small, very low incidence of hypertension, but a very high incidence of reactive hypertension and of maternal bradycardia. So this is clearly the best compromise when using phenylephrine infusion. And of course, this is a starting dose rate. Afterward, it has to be adapted to the individual need of the patient. But an alternative possibility is to use phenylephrine by prophylactic boluses only. And this is very effective, provided that it is used regularly every minute with blood pressure checked at the same rate every minute, and that prophylactic boluses are given as soon as blood pressure starts to decrease. On this practical table for vasopressor use, you can see some suggestion to how to use practically phenylephrine and ephedrine boluses. If blood pressure is in between 90 to 100% of baseline, which is the goal of prophylaxis, this prompt to use repeated phenylephrine boluses every 1 minute to keep this blood pressure in this interval when the maternal heart rate is above 70 beats per minute. Alternatively, if the heart rate is lower than 70 beats per minute, which can occur after phenylephrine use, then it is advocated to use instead ephedrine boluses. If the blood pressure is lower, between 80 to 90% of baseline, it is advocated to use the same vasopressor, phenylephrine or ephedrine, depending on maternal heart rate, but with a dose that is doubled as compared to here. And if hypotension occurs, which means less than 80% of baseline, intraoperative hypotension management should be done according to your local practice that may involve higher dose of phenylephrine or the use of noradrenaline or adrenaline. Smart pumps have been investigated. Smart pumps are devices that are not in routine use for the moment, but they are driven by computer and artificial intelligence. And this study, for example, showed interesting results, but still 47% of patients had at least one reading below 80% of baseline blood pressure, which means they had hypotension. And this was mainly related to movement and shivering artifact that could impair blood pressure readings that were performed continuously with this probe put on the finger. So smart pumps are interesting for the future, but they are not used routinely for the moment. How to use phenylephrine boluses? The best is to use pre-filled syringe, of course. Why? Because on the patient side, this decreases the time period between acute episode of hypotension or decrease in blood pressure and the drug administration, and then also decrease healthcare associated contamination risk. In an urgent situation, the simplest procedure is the safest, and the use of this pre-filled syringe can help managing very quickly hypertension, but also it's very practical just to use it prophylactically to avoid hypertension. Preparation time at least by 50%. In addition, it decreases the cost related to medication error. So what are the take-home messages? Very simple. Phenylephrine should be the first-line vasopressor for elective cesarean section performed under spinal anesthesia. It is advocated, at least this is what we are using, prophylactic intravenous boluses of 50 to 100 micrograms. Some other teams are using also basal infusion rate at a low rate as shown here. So goal is to maintain systolic blood pressure check every 1 minute in between 90 to 100% of baseline, and this will decrease hypotension and nausea and vomiting, and also this will optimize neonatal pH. Ephedrine should be used only as a second-line drug in elective cesarean section in relay of phenylephrine when phenylephrine has decreased too much maternal heart rate. And there, at this, in this circumstance, ephedrine is an interesting second-line drug to avoid a too pronounced decrease in maternal heart rate, which correlate with a decrease in maternal cardiac output. But ephedrine total dose should never exceed 15 milligrams. I have put on this slide the summary of the international 2018 guidelines. And I thank you for your attention, and I am prepared to take any question. Thank you.